So I've been part of the Health Technology Forum for several years. So Pranay Saha, the conference organizer, and he asked me to bring everybody up to date on what we've been doing in Health Information Exchange and Optum recently. So this will be fairly informal. I'll talk a little bit about the history, generally what HIE is, the history of our product line, show a little demo, some of the key features, and then talk a little bit of about the technical architecture underlying it. So this will be informal and interactive if you like. I'll take some questions at the end, but if I'm saying something that doesn't make sense or anybody has something they want answered, please just raise your hand or pipe up and I'll be happy to answer on the spot. All right, so basic overview of what a health information exchange is. So it primarily focuses on sharing clinical data, and I say clinical data as opposed to like claims or financial data. So clinical data could be like patient medication history, problems or diagnoses, history, social history, any known allergies, lab results, transcribed reports, anything like that. So HIE is intended to be able to share that sort of clinical data across multiple providers within a certain regional area. So they're generally formed on a regional basis, anywhere from a city up to a whole state. In some cases, they're tying together multiple different provider organizations within a whole regional community and allowing them to share data. So there could be multiple different hospitals, medical clinics, reference labs, pharmacies, payer organizations, all of them sharing a common population of patients in a certain area and all agreeing to interoperate and share that data with each other. So the ultimate goal here is to produce some common good for the patients and the payers and the providers. They want to reduce the cost of healthcare overall by eliminating duplicate or unnecessary care and reduce the level of medical errors, like harmful drug interactions, and ultimately improve care for everyone. So the history of Optum's HIE products started out as a startup called Axolotl, going back all the way to 1996. We built basically the first real commercial HIE, launched in Santa Cruz, California back then, and it's been slowly enhanced and improved since. It was acquired by Optum, part of United Health Group in 2010. The original, we refer to as the HIE 1.0 or 1.5 products, were single tenant products delivered through software as a service. We had about 30 customers, as regional communities throughout the U.S. But it was somewhat limited scalability. Ultimately kind of reached a wall in terms of how far we can take it. So we're now developing what we call HIE 2.0. It's been in the works for the past couple of years. I know, everybody in the technology industry says, well, you should release early, launch as soon as you can, get something out there. So it might seem like, why have you been working on it for 2 years and it's still in development? Well, there's, in this industry, there's a very, very high bar for having a minimal viable product. You have to be able to meet all the patient safety and consent rules to deliver quite a bit of functionality in terms of clinical data sharing and interoperability. So it's a big thing to build. But the new product is based on a fully modern multi-tenant architecture. So we can essentially operate at much lower costs and be able to share resources, share underlying hardware across all the customers.
So are you taking questions?
Yeah, go ahead.
So between this and the prior one, there is no exchange of information in the contact center. For cost purposes, you are doing it.
You're talking about share
The contact center is one.
Right, so each customer is still isolated from each other. So there's like a wall between each of the tenants that there's no way that one tenant can ever see another tenant's data.
But you don't have something for an IPA or something like that they all come together under a bigger umbrella. That's not.
It is. So we have, I didn't want to get too much into the details of this, but we have a concept of what we call a participating organization within a larger HIE. And so, those organizations, depending on the governance model that's set up there, they can see or not see various levels of data. So in order to make all this work, we're highly dependent on a number of health IT industry standards. I listed some of the key ones here. I'm not going to run through them in detail, but most of you have probably heard of HL7. That's a key industry standard for messaging and documents. So a lot of our data comes in the form of HL7 version 2 messages, CDA-R2 documents. There are also a number of key web service standards that have been defined by integrating the healthcare enterprise, IHE. We've got PICS and PDQ for patient administration, cross-community patient discovery for finding out about other patients and other HIEs, XDS.B for sharing medical records across organizations. So these are some of the key standards that any HIE has to implement.
What's the popularity in radio of version 3 versus version 2? Because I heard that version 3 was seldom used because it's so complex and so on compared to version 2 of HL7.
Yeah, so the question was about the relative popularity of HL7 version 2 versus version 3. So right now, both are used in parallel and they really address different use cases. So when you have, for example, a reference lab that wants to deliver a patient lab result, today it's almost always going to be sent as an HL7 v2 message. But if you're using like the IHE, PICS, and PDQ profiles for basically for finding out, for querying if a patient exists in another system, those are built on top of HL7 v3 messages. It's also common to use the CDA-R2 part of HL7 v3 for documents such as transcribed reports, like if your physician dictates a chart note, there's a good chance that it'll come back in a CDA, some sort of CDA-R2 format. Also, there's a specialization of CDA-R2 called CCD, and then further specializations of that like C32. So those are pretty widely used for sending around patient summaries, like if you're transitioning care from one provider to another provider. There's pretty wide support now for generating that continuity of care document that's got a summary of all the patient's key attributes, diagnoses. So does that answer? Okay. So here's basic diagram of the data flows in HI2. So on the left side, you see the key data sources. So we may have demographic information about patients coming in, like from hospital admission systems, documents like transcribed reports from transcription systems. You have patient consent information. Patients may consent or not consent to have their data shared. Various events coming in, notification like patient was admitted to a hospital. So all that flows in from the data sources into the HIE2 platform in the middle. We take that in, normalize the data, and update a patient index. We have an index of all the patients known in the community with key identity and demographics. We also store copies of the documents. And then there's a subscription manager, you see at the bottom, where users can request to be notified of certain events, and then, such as like the primary use case for that is doctors want to be notified when one of their patients is admitted to a hospital. So we can set up subscriptions, and then here at the bottom, push those notifications out to third-party EMR, EHR applications, like Epic, eClinicalWorks, Allscripts, those types of applications. We can deliver those messages out to the physician EMRs. We also maintain, as part of HI2, what we call a community patient profile. And so that's essentially like an online continuity of care document. And I'll show you that in the demo, but it's a brief clinical summary of all that's really most important about the patient at the current time. All right, so the data comes in various different formats, most commonly HL7 V2 messages or CDA R2 documents. We pull that in through the various interfaces, and then we do some normalization and data mapping to put it in an internal sort of standardized, normalized format that eliminates all the differences between the various data sources. Although there are these HL7 standards, the trouble is that every data source, every clinical system, every hospital, they tend to implement those standards in somewhat different ways. So it's, the saying goes, if you've seen one HL7 interface, you've seen one. I mean, there's unfortunately not a whole lot of commonality between them even now. So there's a lot of implementation work to do that normalization. So we take the data in from the sources on the left side, parse it out, and this could be medications, diagnoses, allergies, basic vital signs, advanced directives, all that different type of clinical data. Pull it into HI2, go through the normalization steps, and then produce an aggregated patient summary that we can feed out to various other applications. So you can essentially think of HIE in a way as kind of a plumbing system or conduit. It's a way to get the right data into a standard normalized format and then push it out to other systems. The patient event subscription that I mentioned, you can define various rules for when you'd like to get notified about a patient. Oops. So again, could be, you can set it as the simplest case. You can get copies of all the data that's coming in for a particular patient, or maybe you only want to hear about hospital admissions or things like that. And that subscription data, as it comes into us in the HIE, if it matches a subscription rule, we can then push it out to those third-party EMR or EHR applications, so it shows up, right in the provider's inbox there. Since this is healthcare, obviously data governance, privacy and security is a key requirement. So obviously we have to, abide by all the HIPAA regulations. There are particular consent rules in a lot of cases, and what makes it especially complex is that there's no one set of consent rules. Many of the US states have their own particular requirements about patient consent and privacy. Some are opt-in, some are opt-out. Some have special rules about consent for minors. So depending on, it's maybe not a hard cutoff at age 18. Some of them allow minors at, age 12 or 16 or whatever to have certain varying levels of control over their data. So we have to be able to support all those various special state requirements. All right, so let me jump in now and just show a brief demo of the current HIE2 product, give you an idea for some of the features. Users can potentially be members of multiple different HIEs. So I'm going to use Sequoia HIE here. Signed in, click over to the patient tab, and search for a patient. I can search by name, date of birth, gender, zip code, and various demographics. So I'm going to look for John Watson. And here he is. All right, so you notice when I clicked on John Watson, it's not immediately allowing me to access the data because I'm not one of his providers. He hasn't already granted a continuity of care document. It's essentially this data here. So we see vital signs, problems, recent encounters, immunizations, vaccinations, allergies, medications that the patient is on. And to an extent, all this data is deduplicated. So if we're getting data feeds in from multiple different sources, if we see the same medication show up from multiple different sources, that will hopefully be deduplicated. So you see here just the limited set that's most relevant. Ultimately, what we think is going on is that HIE is not going to be just a thing by itself. It's really an enabling technology that you need to have in order to do a lot of the other stuff. They tie into the previous workshop where they're talking about big data analytics. Well, you kind of need an HIE to enable that. And you see at least what Optum is doing is we're building out the HIE as an enabling technology that's useful in its own right, but it's you need to have it in order to do a lot of the other add-on stuff that'll make ACOs ultimately successful. And a lot of that ties back to the analytics. But unless you can get the data in the right format, in the right place, at the right time, with the right security and governance, none of that other stuff can work. So I think I'm getting the time signal here. In fact, we're already, 5 more minutes. So any other questions? Anything else anybody would like to ask?
Building on that question, can you talk about who you anticipate your customers to be for this HIE product? Kind of what's the split? Is it primarily at the hospital system level, at the county level? And what's who you think is going to buy the 2.0 product?
Sure. So the question is about intended customers. So it's potentially suitable for both public and private HIEs. Or say, public HIEs have typically been set up as like regional nonprofit organizations that tie together all the different providers, in some cases even competing providers in a certain regional area. And so we've had some of those for the original HIE 1.0, 1.5 product lines that were up to whole U.S. states in some cases that were using our products, for tying together all the providers in that state. Because of some of the funding challenges for the private, for the public HIEs, those will still continue. We may see though that the growth is more on the private side, where it's really like a chain or a hospital chain that's looking for ways to push data out to the independent providers, independent docs in a community, and they want to be able to tie them more closely to the hospital and target those docs that have admitting privileges and be able to push data to them. And also, of course, for the ACOs as a way to enable them to get the data in the right place at the right time in the right normalized format, that then they can apply some analytics to it, which is necessary if they're going to be taking on risk that the ACOs don't really know unless they know. It can't really work unless they can price the risk, and to do that you need to have good quality data.
And I'm so sorry, I'm going to have to interject just because we're running a little bit out of time. So we're going to have to wrap this up, but if you have any other questions for Nick, please meet him in the networking reception at 6:30 p.m.
Yeah, I'll be around for a few minutes. So, but thanks everyone. Again, Nick Radov from Optum. So thanks everybody for listening today.